Welcome to the deep dive. Today we're getting into a really important topic. It's about women who've undergone radiation for gynecologic cancers.
That's right.
And specifically, how hyperbaric oxygen therapy, HBO2, might help with some of those, well, persistent long-term side effects from the treatment.
Exactly.
Yeah.
We're drawing from Chapter 30 of Hyperbaric Medicine Practice.
Mm.
The chapter is called The Use of Hyperbaric Oxygen for Treating Delayed Radiation Injuries in Gynecologic Malignancies.
Right, by Whelan and Killian.
Yep. Think of it as, pulling out the key information on how HBO2 could potentially offer some real relief here.
Okay, so our mission for this deep dive is pretty clear. Really get a handle on how this HBO2 therapy works for problems that pop up sometimes months, even years after radiation for things like cervical, uterine, or vaginal cancers.
Yeah, exactly.
So let's just jump in. What's the fundamental problem that this therapy is trying to tackle?
Well, the core issue is radiation is great at killing cancer cells, obviously, but it doesn't always discriminate perfectly. It can damage nearby healthy tissue. And over time, this damage leads to what the chapter calls a 3H environment. Basically, the tissue becomes hypovascular, fewer blood vessels.
Less blood flow.
Right. Hypoxic, low oxygen, and hypocellular, fewer healthy cells.
Huh. 3Hs.
Yeah. So imagine trying to heal a wound in an area that just doesn't have enough blood supply, oxygen, or building blocks. It's really difficult.
Yeah, makes sense. It paints a picture of why recovery might stall out.
Precisely. See, normally your body needs a good oxygen difference, a gradient, between healthy and damaged areas to signal the growth of new blood vessels. That's angiogenesis.
The repair process.
Exactly. But in radiated tissue, that signal, that oxygen gradient, it's diminished. It's kind of flat. So the body doesn't get that strong signal to build new vessels.
And without that?
Well, healing struggles. And that can lead down the line to things like necrosis, tissue death, or inflammation like cystitis in the bladder, or proctitis in the rectum. And yeah, these can show up quite a while after the treatment itself is done.
Okay, so enter hyperbaric oxygen. How does HBO2 actually step in and help here?
So this is where it gets interesting. HBO2 directly targets that 3H problem. You put the patient in a special chamber, they breathe pure oxygen under pressure.
Right.
And this dramatically increases the amount of oxygen dissolved in their blood plasma, way more than just breathing normal air.
So it floods the system with oxygen.
Pretty much. And that oxygen-rich blood gets forced into those damaged hypoxic tissues. The idea is that this big boost in oxygen can, well, kickstart that angiogenesis process again.
Ah, it restores the signal.
It helps restore that gradient and stimulate the growth of new blood vessels, promoting healing in those areas that were starved for oxygen.
Now, we often hear about HBO2 for similar radiation issues, say in the head and neck area.
Yes, more established there.
So this chapter really focuses on its use for gynecologic cancers. What specific radiation injuries are we mainly talking about here?
We're primarily looking at cancers of the cervix, uterus, and vagina. Those are most commonly treated with radiation in that area. Sometimes ovarian and vulvar cancers, too. And the common delayed injuries, the ones showing up later, are things like soft tissue necrosis, that tissue death we mentioned, radiation cystitis in the bladder, and radiation proctitis in the rectum.
And the chapter mentions these are FDA-approved indications.
That's a key point, yeah. Soft tissue radiocnecrosis, cystitis, and proctitis. They're all FDA-approved indications for using HBO2 therapy. It's not experimental for these conditions per se.
Got it. Okay, let's dig into the evidence then. Starting with radiation proctitis, the chapter highlights 2 randomized controlled trials, or RCTs. What did they find?
Okay, the first one, Cystitic et al. From 2007. They looked at 65 women. All had radiation proctitis after cervical cancer treatment. They split them. One group got HBO2, most had at least 18 sessions, and the other was a control group.
That's the result.
After 6 months, the results were, well, pretty significant. The HBO2 group saw about a 33.6% improvement in their somnolent scores.
Remind us what somnolent tracks.
All right, somnolent is a scoring system doctors use. It's quite detailed. Tracks specific long-term side effects and their severity. Subjective, objective, management, analytic, late effects of normal tissue.
Okay. And the other score?
They also saw a 15.2% improvement in Karnofsky scores, which measure quality of life, like how well you can do daily activities. And crucially, these differences were statistically significant, highly unlikely to be just chance.
That does sound encouraging. What about the second trial? Was it similar?
The second one, Clark et al. In 2008, was actually larger, 100 MV patients, over 100 were women. And importantly, it was double-blind.
Meaning neither the patients nor the researchers knew who got the real treatment.
Exactly. One group got the real HBO2 100% oxygen in 2 atmospheres for 90 minutes, 5 times a week.
Yeah.
The other got a sham treatment, basically normal air at just slightly increased pressure, so it felt similar.
Clever. And the outcome?
After at least 30 treatments, the HBO2 group showed a significant improvement in their average somnolence score compared to the sham group. The difference was quite clear.
Did they mention how many people needed treatment for one to benefit?
Yeah, they calculated the number needed to treat was only 3. That's quite low, suggesting it's pretty effective. You only need to treat 3 people with HBO2 for one to experience that significant benefit compared to the sham.
Wow.
And they also found that the benefits seemed to last based on longer-term follow-up.
So with 2 RCTs, 1 double-blind, showing clear benefit, what's the official recommendation based on this evidence?
Because these are Class I studies, the strongest type of evidence, the recommendation is Level A.
And Level A means?
Level A means there's strong evidence supporting it. The recommendation is basically that HBO2 therapy should be done for radiation proctitis. It should be a standard consideration.
Okay, that's pretty clear for proctitis. Let's shift gears to radiation cystitis, the bladder inflammation. What's the story there?
Right. For cystitis, the evidence is maybe a bit less definitive. There's one small RCT by Van Ophoven et al. From 2007, only 21 women.
Small study, okay.
Yeah. They compared HBO2 6 sessions a week for 5 weeks against a sham. They found 21% of the HBO2 group had a marked or moderate improvement overall.
And the sham group?
None. 0 improvement in the sham group based on that global assessment. The HBO2 group also had significantly better pain scores, and there was a trend, not quite statistically significant, but leaning that way towards better urinary urgency control and bladder volume.
So a positive signal, but from a small trial. Is there other supporting evidence?
There is. Several retrospective studies looking back at patient records like Lee et al. And Chong et al., and a prospective observational study by Bevers et al. Have shown good results, particularly for hemorrhagic cystitis, the kind with bleeding.
Any highlights there?
Well, the Bevers study was interesting. They observed patients getting HBO2, and all the gynecologic cancer patients in their group became hematuria-free, meaning the bleeding stopped completely.
That sounds promising.
Yeah.
But limitations?
Always. Retrospective studies have inherent biases. Chong's study, for example, was mostly men with prostate cancer, not gynecologic. Bevers' study didn't have a control group. And there was another small retrospective study by Del Pizzo that actually showed poorer long-term outcomes. So it's a bit mixed.
Right. So putting it all together, what's the recommendation for radiation cystitis?
It lands at level B.
Which means?
Level B suggests that, yeah, HBO2 therapy should be considered. There's decent evidence, but it's not as rock solid as for proctitis. More research would be helpful, especially to figure out which specific patients with cystitis are most likely to benefit.
Okay, makes sense. Level B, consider it. Now, what about the third area, radiation necrosis, the tissue death?
Yeah, necrosis. Here, we don't currently have any RCTs specifically in gynecologic cancers. Most of what we know comes from looking back at cases, retrospective studies.
But what do those studies generally show?
They generally show pretty good results, actually. Good outcomes in healing those necrotic wounds, even fistulas sometimes. And importantly, we have to remember, HBO2 is already a standard treatment for radionecrosis in the head and neck.
Which behave similarly.
The underlying pathology, that 3H environment, and the response to oxygen is thought to be very similar to soft tissue radionecrosis elsewhere in the body.
The chapter mentions a head and neck study by Marks et al. What was the takeaway there?
Right, the Marks study wasn't randomized, but it was controlled. It showed the group getting HBO2 before and after surgery for head-neck radionecrosis had lower infection rates, less wound breakdown, and healed faster than the control group.
So strong supporting evidence from a related field.
Exactly. It provides a solid biological rationale. And then the retrospective studies, specifically in GYN cancers like Williams et al., Feldmeyer et al., they back this up. Williams, for instance, reported complete healing in like 13 out of 14 women with necrosis.
That's a high success rate.
Yeah, and Feldmeyer found 20 out of 23 gynecologic patients healed with HBO2. Fink also reported most patients showed significant improvement. So the clinical experience seems positive.
Okay, so given the rationale from head neck and these positive retrospective findings, what's the recommendation level for necrosis in GYN cancers?
Also level B, same as cystitis. HBO2 therapy should definitely be considered. The lack of specific RCTs keeps it from level A, But the consistency across retrospective studies and the strong parallel with head and neck makes it a very reasonable option to explore.
Level B for cystitis and necrosis, level A for proctitis.
Got it. Now, knowing these treatments exist, how often do these delayed radiation injuries actually happen? The chapter gives some numbers.
Yeah, it looks at data from 2 Wisconsin medical centers between 2005 and 2010, Froedtert Memorial Lutheran Hospital, FMLH, which is a big academic center, and Aurora St. Luke's, ASLH.
And what was the difference?
FMLH had a higher average annual incidence rate. About 13.8% of their radiated GYN patients developed some kind of delayed injury. ASLH was lower, around 5.5%.
Why the difference, potentially? Could be case complexity, maybe different treatment protocols, patient populations. The academic center might see more complex or heavily pre-treated cases.
Okay. And within that FMLH data, were certain cancers more prone to complications?
Yes, interestingly, patients treated for cervical cancer and vulvar cancer had the highest rates, both around 23%. Ovarian cancer had the lowest rate at about 6.7%.
And the most common type of injury they saw?
Soft tissue necrosis was the most frequent one reported in their delayed injury dataset. They actually didn't report any cases of cystitis specifically labeled as a delayed injury in that particular dataset, which is interesting.
But still, 13.8% or even 5.5%, that suggests a fair number of women might face these long-term issues.
Absolutely. It's definitely not a rare occurrence. Even 5% means 1 in 20 women, potentially. That's a significant number of people who could potentially benefit from knowing about treatments like HBO2.
Okay, so let's talk practicalities. What does HB2 therapy typically involve, and what's on the horizon?
Well, as we touched on, it's usually not just 1 or 2 sessions. For angiogenesis, for stimulating that blood vessel growth, you typically need a course of daily treatments, often 20, 30, sometimes 40 or more sessions.
So it's a commitment.
It is, yeah. Daily sessions, usually Monday to Friday for several weeks. And long-term follow-up is important to really see if the benefits hold. Cost can also be a factor, definitely something to discuss.
Any ongoing research we should know about?
Yes, there's a big study called the Hyperbaric Oxygen Radiation Tissue Injury Study, or HOTIS. It's looking at HBO2 for radiation injuries across various cancer types. The results from that could give us even clearer evidence down the road.
And side effects. Is the treatment tough to tolerate?
Generally, no. The side effects are usually pretty mild. The most common thing is some ear discomfort, like when you fly, due to the pressure changes. That's usually manageable. Some people might experience temporary changes in vision, but serious side effects are rare.
Good to know. Okay, so let's try and wrap this up. What are the main takeaways from our deep dive today on HBO2 for these delayed radiation injuries?
I think the big picture is that HBO2 shows real promise. The evidence is strongest for radiation proctitis. That's a level A recommendation, meaning it should be a standard consideration.
Right.
For radiation cystitis and radiation necrosis, it's a level B. So definitely something that should be considered as a valuable treatment option, even if we'd like more research for cystitis in particular.
And for you, listening, why is knowing this so important?
Well, if you or someone you care about has gone through radiation for gynecologic cancer, understanding these options is crucial. These delayed effects can really impact quality of life.
Yeah.
And HBO2 offers a non-invasive way, meaning no surgery, to potentially heal these damaged tissues, maybe avoid more complex procedures later, and just feel better day to day.
All right, so here's a final thought to leave you with. Given these potential benefits, especially for proctitis, and the relatively low risk profile, why isn't HBO2 maybe more routinely discussed or integrated into the follow-up care for women experiencing these delayed radiation injuries from gynecologic cancers?
That's a really good question.
What other questions should you or your doctor be asking to make sure this possibility is on the table if it could genuinely help improve quality of life? Something to think about. Thanks for joining us for this deep dive.